So the most common congenital heart lesions we see in children is left to right shunts. Okay, left to right shunts are the most commonest. If you see the number here, you see the most commonest among them is also the VSD. You see 30%. No one is coming for 30% throughout this whole table. Next, you get PDA, most probably in preterm babies, but the second common is the PDA. Then you're getting atrial septal defect. Okay, to some extent atrial septal defect and pulmonary stenosis, you see 7%. Rest all is coming like to 5%. Most rest all is 5%. Okay, so the most commonest you'll remember always is the VSD. Okay, they can this can come in the exam. And patent ductus arteriosus, sorry, persistent atrial duct. Okay, that is patent ductus arteriosus. It is 12%. Then ASD 7% and also pulmonary stenosis is 7%. Rest all is coming 5% or less than 5%. Okay, so left to, you will divide them into left to right shunts, right to left shunts. Okay, common mixing, outflow obstruction in a well child, outflow obstruction in a sick neonate. Okay, so left to right shunts, again the most commonest is the VSD. Left to right, so if this is the heart, so let's draw here, this is left and this is right. So in left to right you will have left to right shunting. So the most commonest is the VSD, then the patent ductus arteriosus, then the atrial septal defect. So in the atrial septal defect you will have here, but in the patent ductus arteriosus we know that there will be a connection between aorta and the pulmonary artery. It will be here. Okay, between the aorta and pulmonary artery. So then we will have right to left shunts. So reversal now. Let's take blue color. So right to left shunts, which is usually the baby will present as blue. So I am using blue color here because the baby will present to you in cyanosis. So most probably what it is, tetralogy of Fallot and transposition of great arteries. If you see here, the percentage both are less, 5% compared to VSD, which is 30%. So most commonly you see is the VSD. It's just 5%. Both right to left shunts is just 5%. Then common mixing. Common mixing you see in the atrioventricular septal defect, that is AVSD. We all know that AVSD is common in Down's children. Okay, VSD is also common in Down's children, but AVSD most commonly it comes in Down syndrome, and it is just 2%, very less. Okay, only this is the only condition which presents very less, that is 2%, and it is common in Down syndrome. We have to remember that. And here you will have common mixing. The child will be breathless as well as blue, both breathless and blue. Okay, then our next point is the outflow obstruction in a well child and outflow obstruction in a sick neonate. That means the neonate can come to you in a collapsed with shock. Most commonly, the neonate coming with collapsed and shock will be coarctation of aorta, but still we have four left heart lesion, sorry, four left heart outflow tract obstruction, left heart outflow tract obstruction, which can present as the sick neonate collapsed with shock. One is the coarctation of aorta, another is the critical aortic stenosis, hypoplastic left heart syndrome, and also I think interrupted aortic arch. Okay, these four left heart outflow tract obstruction can present to you with collapse with shock. They are also telling outflow obstruction usually in a well child, just asymptomatic with a murmur, can present with pulmonary stenosis and aortic stenosis. They can present at a later age. Okay, but there are some conditions like right right heart outflow tract obstructions. Okay, right heart outflow tract obstructions, they can present as cyanosed neonate in the neonatal period. They are again any like critical pulmonary stenosis, tricuspid atresia. Okay, pulmonary atresia, tricuspid atresia, all right heart lesions can present to you as a cyanosed child, that is cyanosed neonate. And also severe TOF, severe tetralogy of Fallot, critical pulmonary stenosis, tricuspid atresia, and pulmonary atresia. Okay, so these are the lesions we see in congenital heart disease. So anyone has comments before we go further? Is it clear for all? And someone is asking something in the chat. Any questions you can ask here, no problem. Okay, so we all got to know the means what is the commonest congenital heart disease and how do we go with them. Okay, so let's go to next now. Just you should know the etiology in general. Okay, general, we should know the etiology. So the commonest etiology for congenital heart disease is the genetic. Whenever it is there, you can do some genetic screening as well. Here he has very clearly written genetic causes are increasingly recognized in etiology of CHD now in more than 10%. In more than 10% of the cases, genetic causes have been recognized. How they can affect, for example, they may affect the whole chromosome, like we see in Down syndrome, a whole extra chromosome you will have. Okay, they may affect as point mutations. Okay, and micro deletions. I think Williams syndrome, right? Williams syndrome is due to deletion, as I remember, but if anyone remembers, please let us know. And any example for point mutation also you can give. Go back and check. I think Williams syndrome is due to microdeletion. Okay. Cardiac screening should be part of care of children with multisystemic genetic disorders. So anyone who has multisystemic genetic disorders, you are seeing some other disorders in other system, you will also do the cardiac screening. Okay. Polygenic abnormalities probably explain why having a child with congenital heart disease doubles the risk for subsequent children. Okay, they can also be familial, like polygenic abnormalities will explain you why a child with congenital heart disease doubles the risk for subsequent children. So any child with congenital heart disease in the family, the other children can also have, they are at risk. The risk is higher still if either parent has congenital heart disease. So there is something called relation to familial also here. Like if one child is having congenital heart disease, there is a double risk of subsequent children having congenital heart disease, and the risk will be higher even if the parent has congenital heart disease. So if it comes as an history case or something, family history and other siblings having congenital heart disease becomes very important here. And a small number is related to external teratogens, like maybe the consumption of alcohol during pregnancy or any drugs during pregnancy. Okay, these are the external teratogens. Okay. No need to go for circulatory changes and all. We'll just go to what is needed for us. Okay, some causes you should know commonly and the associations, because this can help you in the exam. Like in the rubella infection, you see it in the rubella infection, that is you can consider as History of torch infections becomes important here for the maternal. Okay. So in rubella infection, you can see patent ductus arteriosus and also peripheral pulmonary stenosis. See here, it's very high, 30 to 35%. Then SLE can present as complete heart block. Okay, maternal SLE, a mother having SLE. Okay, maternal disorders here. Mother having SLE, the child can present to you, the neonate can present to you with complete heart block. Okay, then diabetes mellitus, incidence increased overall. A mother having diabetes, if she gives you if you ask a prenatal history and she tells that I had diabetes during my gestation, that is gestational diabetes, you will think of an they may have congenital heart disease, so you will examine CVS and also consider echo if needed. Okay. So incidence is increased overall. Then maternal drugs, what we said, external teratogens, here he told, right? The external teratogens which can cause is the warfarin and the fetal alcohol syndrome. See, as I told you, consumption of alcohol during pregnancy can cause ASD, VSD, and TOF, tetralogy of Fallot. And also warfarin therapy is again associated with pulmonary valve stenosis and PDA. So in any, if you want to take the history, like you got a child with cyanosed neonate in the video station, and what history you will take, if it is asked to you, you will also tell about maternal drug ingestion. Did she take any drugs or alcohol during pregnancy? Okay, this becomes important in a cyanosed neonate. Next, chromosomal abnormality. So you have Down syndrome, as I told you before, AVSD and VSD, and it is 30%. Okay. Here he has given the frequency, how commonly you see this. Next, you have all the trisomies you can see here, 21, 18, and 13. So in 18 and 13, you will have complex congenital heart disease. So to remember, what I do is not to get confused, E for E. That is 18 is 18, starts with E. So 18 is always Edwards. If you remember like this, you will remember that trisomy 13 is Pato always. Okay, if you get confused sometimes between which is 13, which is 18, just remember as E for E. Means 18. Trisomy 18 is always Edwards. That means obviously trisomy 21, no one will forget. Definitely it's Downs. So obviously trisomy 13 will be Pato. Okay, so let's continue. Then Turner's, again, Turner's is the commonest case in the exam. You can have aortic valve stenosis and coarctation of aorta. Okay, they can also, coarctation of aorta is the commonest presentation, but can also have aortic valve stenosis. Okay. Next is, yes, this is the deletion I was asking. Chromosome 22q11.2 deletion. You see, so aortic arch abnormalities. Okay, this is DiGeorge syndrome. 22q11.2 deletion is DiGeorge syndrome. You can see aortic arch abnormalities and also tetralogy of Fallot, common atrial trunk. Okay, they say interrupted aortic arch. It is there here in this book later. We can just go through it. And then again, I told you microdeletion, I remember Williams syndrome. So you see, this is also DeGeorge and William are the examples of deletion here. So 22q 11.2 deletion, this is DeGeorge, and Williams is 7q 11.23 deletion. You have to remember, because Williams and DeGeorge are the common cases in exam. Okay. Then Noonan's syndrome, it is mutation. We read there the causes in the chromosomes can be the whole chromosomal abnormality, can be a deletion, can be a point mutation. So for deletions, the example is the DeGeorge syndrome and the Williams syndrome. And for the mutation, Noonan syndrome, PTP N11 mutation. Okay. Again, you will have what? Hypertrophic cardiomyopathy, atrial septal defect, and pulmonary valve stenosis. Then Duchenne's muscular dystrophy, you can see cardiomyopathy. Okay. So how the congenital heart disease commonly presents? So sometimes what happens by the anomaly scans, what you do at 20 weeks, by the antenatal scans, they can be detected. Okay. Sometimes it can be clear by the antenatal scans. So this can, the mother can tell you the history that yes, scanning was done, and before scanning we were alarmed that this my child has so and so. So we will deliver the child in a tertiary cardiac. So one is the antenatal cardiac ultrasound diagnosis. Next is the sometimes diagnosis is sometimes you see a child with a heart murmur. This can be detected late also. It means in a well child, sometimes in pulmonary stenosis and aortic stenosis, which are not critical. Critical, usually they present in the neonatal period. Which are not critical can present to you at any time in the as an accidental diagnosis. Okay. As an accidental finding. So detection of a heart murmur, then they can present with heart failure, and as a collapsed and shock neonate, and as a cyanotic neonate as well. Okay. Let's move ahead. So we will not go into details. It can be read later. Only I will tell you the important points only here. So here you see here what he has written, 18 weeks and 20 weeks of gestation. So checking the anatomy of fetal heart has become a routine part of fetal anomaly scan. We should know this at least always. Okay. Fetal anomaly scan performed in high income countries between 18 to 20 weeks gestation can lead to 70% of those infants who require surgery in the first 6 months of life being diagnosed antenatally. Okay. So if abnormality is detected, detailed fecal echocardiography is performed by the pediatric cardiologist. So we should know that the anomaly scan here, which is performed at 18 to 20 weeks, will be a screening scan for us to detect the congenital heart disease, and it can help you to find out the which congenital heart diseases which may need immediate attention after birth, like hypoplastic left heart syndrome, or some critical pulmonary stenosis, aortic stenosis, or coarctation of aorta, and the child has to be born in the tertiary cardiac center. Next, heart murmurs. This is important here in heart murmurs. Like, the features of an innocent murmur can be remembered as 5S. Asymptomatic, soft, systolic, left sternal edge. Okay, but you can see also in another places also left sternal edge usually. This is you can see the stills murmur, and also baby he's telling left sternal edge because you see if you say you may have an innocent murmur in the pulmonary area, that is pulmonary flow murmur, which you see in the left second intercostal space, and the stills murmur is best heard in the left lower sternal edge. So this is the reason he's telling left sternal edge. Okay, other than venous hum, these two murmurs which are common will both will occur in the left sternal edge. This is the reason he is telling. So asymptomatic, soft systolic, left sternal edge. Next is we should know the causes of heart failure. Okay, next we should know the causes of heart failure and the age, depending upon the age. Suppose you have different ages of children in the exam, so you will prioritize which one you will put the reason here. Okay, that is why you should know the causes of heart failure. So here the causes of heart failure will start with the neonates. Neonates always remember as critical things will present in the neonate. Critical. Okay. That means duct obstructed lesions. Obstructed, and they should be duct dependent. Okay, obstructed and duct dependent systemic circulation. I told you before 4 points here: hypoplastic left heart syndrome, critical aortic valve stenosis, severe coarctation of aorta, and interrupted aortic arch. So always remember critical. It should be critical and severe. Then only they will present to you immediately during the neonatal period. So the commonest presentation for the heart failure in neonates will be critical aortic valve stenosis, severe coarctation of aorta, hypoplastic left heart syndrome, and interruption of aortic arch. If it is not critical, if it is normal aortic valve stenosis, it can present to you in the later life. It in a well child. Okay. So infants, wherever there is high pulmonary blood flow, we all know that wherever there is left to right shunt, okay, this is left and this is right. Any condition which causes left to right shunt, since the blood is coming more, will go through the pulmonary arteries to the heart, right? So any condition which causes increased pulmonary blood flow, like VSD, AVSD, and large patent ductus arteriosus. Okay, this is in the infants. Next, older children and adolescents. Older children and adolescents, what happens if VSD is left untreated? It will reverse, there will be reversal of shunt. So it goes from right to left side. Okay, this is the Eisenmenger syndrome, and they will present to you with right heart failure only. Right heart failure only. This you have to remember. Okay, Eisenmenger syndrome is the reversal of shunt when you leave the AVSD or VSD untreated, and it can present only with the right heart failure. Then older children, you see what else? Rheumatic heart disease. This is the commonest acquired heart disease we see, and the cardiomyopathy. It may be due to genetic causes, also the cardiomyopathy. So how the congenital heart disease can present to you? This is very important. Again, you have always left to right shunt, right to left shunt, common mixing, well children with obstruction, sick neonates with obstruction. So left to right shunt, usually they will have heart failure, means the pulmonary blood flow is more. So you see pulmonary edema. So since there will be pulmonary edema, you can have breathlessness. And if the VSD is small, the child can be asymptomatic. Okay, like large VSD and AVSD, they can present with breathlessness. And if the VSD is small, they will be asymptomatic. Again, what happens? As I told you before, the right to left shunts, the child will be present with blue. Okay, so what happens here? Tetralogy of Fallot and transposition of great arteries. Usually the child will be cyanosed. In common mixing, where there is both mixing, okay, breathless and blue, that is AVSD, and complex congenital heart diseases, where there can be mixing of both the oxygenated and deoxygenated blood. Well, children with obstruction, as I told you, they can be asymptomatic as long as the aortic stenosis and pulmonary stenosis is not critical. They can present you at an older age. Okay, so or it can be an accidental finding when you are auscultating the chest. There can be a murmur and you can send the child for an echo to check like this. And it will be adult type coarctation of aorta. But neonates, usually whoever is critical will present immediately. Sick neonates with obstruction, it will be collapsed with shock. It can be coarctation of aorta or hypoplastic left heart syndrome. Okay, just 1 minute break only because Azan is going on. So the diagnosis will be a question for us always. Any case congenital heart disease come, we should know generally what we will list out. Okay. So if congenital heart disease is suspected, a chest radiograph and ECG should be performed. So never forget to mention chest radiograph, ECG and echo. Although rarely diagnostic, they may be helpful in establishing that there is an abnormality of cardiovascular system as a baseline assessing future changes. So obviously they are not diagnostic to you, but they are helpful to you. Echocardiography, this is very important point you have to tell here. Okay, any case, echocardiography combined with Doppler ultrasound enables almost all cases of congenital heart disease to be diagnosed. So you'll just echocardiography along with Doppler ultrasound will help you in diagnosis. Even when a pediatric cardiologist or pediatrician with expertise in cardiology is not available locally, a specialist echocardiography opinion may be available via telemedicine, or else transfer to cardiac center will be necessary. An urgent specialist opinion is required if the child is hemodynamically unstable and if there is severe heart failure. So heart failure, okay, or if there is cyanosis with oxygen saturation less than 94% due to heart disease, or when there is reduced volume pulses. So they can present with what? Shock. Unstable here means what? They can present with shock, that is reduced volume pulses, or they can present to you with heart failure or cyanosis. So whenever the child is hemodynamically unstable, that is it is in severe heart failure, or there is cyanosis with oxygen saturation less than 94%, or heart disease with reduced volume pulses, shock. All these you will involve the immediate specialist opinion, and you need immediate echocardiography with Doppler ultrasound. This is the diagnostic. So 3 things you will never forget. How do you want to investigate this case if this question is asked? So ECG, chest X-ray, and echocardiography, and echocardiography will be the diagnostic test. So we have 2 nice cases here, which can come as an video, or it can come as also, because now there is no patient, it can come as clinical case as well. Okay, so we'll go through these cases first before going to ECG. So after going through these cases, we will take break for 20 minutes for the prayer. Then we will come back. Then we will start with the VSD, ASD, and all those things, and their ECGs and the chest X-rays. Okay. So after these 2, we will take a short break for 20 minutes. So shock. Here, suppose, as I told you before, the presentation of shock is usually left heart outflow tract obstructions, and it should be severe in neonates. And the presentation of cyanosis will be right heart outflow tract obstruction, severe in neonates. So here it is presentation of shock. So your differential diagnosis will be left heart outflow tract obstructions. So here a 2-day-old baby has been discharged home the day after delivery following normal routine examination. So when the examination was done for this baby, it was normal and it is 2-day-old and discharged. He suddenly collapsed and was rushed to the hospital. He was, see the words here, he was pale and gray lips. The right brachial pulse could be just felt and the femoral pulses were impalpable. So, but when he was examined to start with, he was fine, normal routine examination, and he was discharged home. But in the home he collapsed and he had pale and gray lips. Right brachial pulse is feeble and femoral pulse is impalpable. His liver is markedly enlarged. Blood gases show severe metabolic acidosis. Okay, so the differential diagnosis was congenital heart disease, septicemia, and inborn error of metabolism. So if such a case comes, you can put these 3 as your differential diagnosis: congenital heart disease, septicemia, inborn errors of metabolism. So how did they do? How did they work out this child? He was ventilated and treated with volume support. Okay, because he is in shock. Okay, he presented to you pale, gray lips, and there is no femoral pulses palpable, and liver is also enlarged. There is hepatomegaly. So and also your this is septicemia. So blood cultures were taken and antibiotics started for possible sepsis. Blood and urine samples were taken for amino acid screen and urine for organic acid. So keeping this in your mind, everything was done for the child. Okay, blood cultures were sent and metabolic screens was done. As femoral pulses remained impalpable, a prostaglandin infusion was started. So sometimes, there can be a situation that you don't have a facility to do echo at that time. Since you started volume support and still the femoral pulses were impalpable, a suspicion of congenital heart disease duct dependent was made and a prostaglandin infusion was started. Within 2 hours, he was pink and well perfused and acidosis was resolving. So severe coarctation of aorta was diagnosed on echocardiography. Okay, he had developed shock from left heart outflow tract obstruction once the arterial duct had closed. First day he was fine because still the artery duct was open, patent ductus arteriosus, still the duct did not close. As soon as the duct closed on the second day, he came with this presentation. So this is the take home message. Maintaining ductal patency is the key to early survival in neonates with duct dependent circulation. So whenever you suspect a congenital heart disease and the child is in shock, pale, acidosis, it will be usually left heart. If he is cyanosed, it will be right heart. So this child was presenting with pale, and also there was liver enlarged. I think he was also going into failure. So here, duct dependent coarctation. This is the duct dependent coarctation. If you see this picture here, usually the coarctation here is preductal. It is before the duct here. Okay, this is the coarctation you have here. Now the mixing was happening here. Even though the blood cannot come here, the blood from the pulmonary artery is going here and supplying the systemic circulation. But when the duct got closed, what happened? Suddenly there is a block here for the systemic circulation. So there is no supply, means very less or no. So he went into shock. This is the mechanism here. It's shown beautifully here. So duct dependent coarctation. The systemic circulation is maintained by flowing of right to left across the ductus arteriosus, a duct dependent circulation. So here what happened in this child when he was day 1 old, he was receiving blood through this patent ductus arteriosus. Once it got closed, he presented to you with the shock. So now again, what is your treatment? You will try to keep it open. How do you try to keep it open? By giving prostaglandin. But whenever you give prostaglandin, you should know some of the points here, which can be asked to you in the exam. Like you will tell that this will be, you will involve the neonatal intensivist, and you will admit the child in NICU under cardiorespiratory monitoring, because there are side effects of prostaglandin. So who can tell me the side effects of prostaglandin?
Yeah.
Yes. Apart from that,
hypotension,
Hypothermia. Fever.
yes, temperature. Yes. So apnea, temperature can be raised, and hypotension as well. So apnea is the most important thing, and sometimes they may need ventilatory support due to this. So it cannot be given in a ward setting or anywhere. It has to be in the neonatal unit under a neonatal intensivist. We will start next after 20 minutes with this heart failure. It can come, okay. Heart failure presentation. The first presentation we saw was the neonate presentation, but the same thing can come in the cyanosed. We will discuss that also, and then we will go for this heart failure, and then we will start with the ECGs and chest x-rays. Okay, so we will start back after 20 minutes. So always one point we should remember, that routine normal neonatal examination does not exclude heart disease. Okay, like in the first case we saw, the child had routine normal examination, he was discharged, then he came with shock, collapsed and shock. And here also again the same story will come. Okay, but here it was there the child was just 2 days old. Here the child is 5 weeks old. Okay, now let's start. So here what is written here, 5-week-old female infant was referred to hospital because of wheezing, poor feeding and poor weight gain during the previous 2 weeks. Okay, they observed over the 2 weeks that the child is not feeding well, poor feeding. So since poor feeding, poor weight gain, and also there is some wheezes in the chest. Before this she had been well. Now 5 weeks means 3 weeks the child was well. From 2 weeks the child is sick now. Okay, Her routine. Okay, again see what's written here. Her routine neonatal examination had been normal. Then what? She was tachypneic, 50 to 60 breaths per minute. Okay, 5 weeks old, 50 to 60 breaths per minute, and there were some sternal and intercostal recessions. That means shortness of breath, or you can say distress. The child had an RR of 50 to 60 and the child was in distress. Pulses were normal. Okay, that means in the previous case the femoral pulses were feeble. Here the pulses are normal. There was a thrill and a pansystolic murmur at the left lower sternal edge, and slightly accentuated pulmonary component of the second heart sound. Okay, so all the features here going with VSD, like pansystolic murmur at the lower left sternal edge, and there is an slightly accentuated pulmonary component of the second heart sound. This happens due to the increased blood flow, which we will discuss. There were scattered wheezes and the liver was enlarged, palpable 2-finger breadths below the costal margin. The ECG was normal, okay, unremarkable. The chest radiograph showed cardiomegaly and increased pulmonary vascular markings, okay. So the echocardiogram showed, when they did echocardiogram, this is the finding, moderate sized VSD. So this is the echo. Treatment was diuretics and captopril. So you can remember treatment, medical treatment for heart failure is diuretics and ACE inhibitors like captopril. The VSD closed spontaneously at 18 months. So this was moderate sized VSD. I think they gave her a waiting period. And 18 months it closed spontaneously. The infant developed heart failure from moderate VSD, presenting several weeks of age when pulmonary resistance fell, causing increased left to right shunting of the blood. The defect closed spontaneously. So this was the case here. So what is A? A is the echocardiography showing medium-sized muscular ventricular septal defect. Suppose if you get a video, they can also show the child along with some pictures also. I am not sure how the videos of CVS comes in the exam. Maybe they can show. So here it's very clear, this defect, okay. There is a defect here. So there is left to right shunting of the blood. This is the first picture, okay. Now the second picture, B, the color Doppler shows left to right shunting. You can see here, this is left ventricle and this is right ventricle. And this is the color Doppler showing the left to right shunting. Okay. Then there is also small right to left shunting. Okay, very small here. This one, blue. Okay. There can be small right to left shunting also during the diastole. So not during the during the systole, that is when the left ventricle contracts. As we all know that the left ventricular pressure will be higher than the right ventricular pressure, there will be clear left to right shunting. But during the diastole, there is a chance that some blood can come this side. This is what he's telling, small right to shed during the diastole. Okay, but no need to comment about that. Here we will remember presently it's a moderate sized VSD and there is right to left. So what we have to remember here is a child like 5 weeks old presenting with heart murmur, presenting with the features of heart failure like poor feeding, shortness of breath, tachypneic, in distress, and there is a pansystolic murmur in the left lower sternal edge. And also due to the increased flow, what happens here is, if this is the this is the VSD and this is the left to right shunt. What happens? There will be increased flow here to the pulmonary artery. Okay, so due to this increased flow to the pulmonary artery, you can hear this second heart sound, slightly accentuated pulmonary component of the second heart sound, and also they will have the pulmonary edema and hepatomegaly. So now we will go for ECG in children. So for ECG in children, important features, what you can see is the arrhythmias. Okay, and other things you should know, what is superior QRS axis. Superior QRS axis means, just remember it as negative deflection in AVF. Okay, later all these pictures will come, what is superior axis and everything. You have to remember that in lead AVF there will be negative deflection. If there's negative deflection in lead AVF, it is called as superior QRS axis. Other thing is right ventricular hypertrophy, you see very commonly. Okay, it will be upright T waves in V1 over the age, over 1 month of age. Okay, I think up to 1 month of age, upright T wave in V1 is normal. Beyond that, it is not normal. Okay, usually you should have inverted T waves. So in upright T wave in V1 suggests right ventricular hypertrophy. Next, you see left ventricular strain pattern, that is inverted T wave in V6. If this is the V6, okay, the T wave should be upright normally, but here in left ventricular straight pattern, the T wave can be inverted. Okay, inverted T wave. Next is the pitfalls, but all these things, if we go case by case, we will understand. It doesn't matter. P wave morphology is rarely helpful in children, but still we have to remember sometimes wherever there is right atrial hypertrophy and left atrial hypertrophy. Patient with right bundle branch block, sorry, partial right bundle branch block can be present in most normal children also. Okay, most are normal children, partial RBB, but although it is common in ASD, atrial septal defect can present as right bundle branch block partial, but it can be normal also. You have to remember this. Then sinus arrhythmia is a normal finding. Please, all of you, take care of your mics because it will be difficult for me. Okay. Okay, now this is the ASD. So ASD, as we said, there can be secondum atrial septal defect, which is the most commonest. Okay. So here, what is happening? What are the features you see in ECG, USD, usually in secondum ASD? You have to remember that this is the ECG, like it you see like an M. Okay, this is called RSR pattern, RSR pattern in V wave. So if we start here, this is the R wave which is starting, then this is the S wave, and again you get an R wave. So this is called RSR pattern. Okay, so this you see in V1. The RSR pattern in V1 is the characteristic of secondum ASD. I don't know ASD. I don't think it's a very common case in exam, but still out of the way, if it can come, we should know. Then this is the, and also you see what right axis deviation and partial right bundle branch block. We read before that the partial right bundle branch block can be normal also. It can be present in normal children as well. And another thing, your differential will be atrial septal defect for that. This is the ECG finding you see in secondum. And we told that any AVSD, always remember any AVSD, whether it is partial or full, you will have this superior axis. What is superior axis? Superior axis is nothing but just in the lead AVF. We know the different leads in ACG. Just in the lead AVF, you will have negative deflection. When you have negative deflection, this is superior axis. Okay, suppose if you tell what do you see in ECG, you say there is an AVSD case, and if it is asked what do you see in ECG, you will say superior axis. What is superior axis? You should know to tell only this much: negative deflection in lead AVF. Okay, now this is the murmur they are talking about. Go down. See here, he gives every description of the pictures. Okay, this is the figure A. So what is he telling here? The ostium secundum atrial septal defect is deficiency of foramen ovale, is a deficiency of foramen ovale and the surrounding atrial septum. So it is clear here, this one. Okay, this one here is this is the atrial secundum defect. Next is the B. He's telling what partial atrioventricular septal defect is deficiency of atrioventricular septum. Okay, this is, there will be deficiency of both atrial and ventricular septum, but it is not complete. It is partial. So whenever as I told you before, whenever there is an AVSD, remember the ECG finding is superior axis, which is the negative deflection in AVF. This is the murmur. They have represented fixed split. Okay, fixed split of second heart sound, which is the commonest finding we see. Then the chest radiograph. So always we know that in any left to right shunt, what happens? There is again here what is happening, left to right shunting, right? So there is enlarged heart, that is the cardiomegaly, and since there is left to right shunting, more blood is entering the right ventricle and more blood is going to the lungs. Because there is shunting here, more will enter right ventricle, more lung will go to the lungs. So what do you see here? Enlarged pulmonary arteries and increased pulmonary vascular markings. Everything will work here. Even the right ventricle will work, even the left ventricle will work, right ventricle will work. The same thing happens in VSD also. You will understand better in VSD, but just I'll tell here. What happens whenever there is left to right shunt, more blood is entering the right atrium. So more blood is entering the left ventricle. So more is entering here the pulmonary artery. So you will have what? Enlarged pulmonary arteries. So more blood will go into the lungs. So increased pulmonary markings. So again, more blood will enter back through the pulmonary veins to the left heart. Okay. So ultimately you will have cardiomegaly, that is enlarged heart. So because of increased flow through the pulmonary arteries, enlarged pulmonary arteries, and you will see increased pulmonary vascular markings in the lungs. So if you remember the pathology, you can remember the chest X-ray findings. Okay. Then this is the figure G is example of occlusion device used to close secundum atrial septal defect. So how do you close the secundum atrial defect? This is the closure device they use. Example of occlusion device used to close secundum atrial defect. So investigations in ASD is a chest radiograph shows cardiomegaly, enlarged pulmonary arteries, increased pulmonary vascular markings. Then in secondum ASD, as I told you, remember RSR pattern, or you can remember it as M. Okay. A partial right bundar blanch block is common but may occur in normal children. Right axis deviation due to right ventricular enlargement. As there is more flow to the right atrium and right ventricle, even the right ventricle will enlarge. So you can have right axis deviation as well. Then in partial AVSD, always superior axis, mainly negative in AVF. This occurs because there is defect in the middle part of the heart. Middle part of the heart where the atrioventricular node is. This displaced node conducts to the ventricles superiorly, giving the abnormal axis. This is the reason he has given, but I don't think they will ask this in the exam, but this is good for your knowledge. Why you see superior axis in partial AVSD. So what happens here is, it's just one sentence only. Like, due to the AVSD, normally we have the SA node here and AV node here, right? So due to the AVSD, what happens? Maybe the AV node is displaced downwards. It's not here now. It is not here now. It's displaced downwards. The displaced node conducts the ventricles superiorly. So here the conduction will go in this way, not like the normal conduction which comes in down way. This is the reason you see negative deflection in AVF. This is the explanation they are giving. But if you get a AVSD case, you will say the ECG finding is superior axis. Okay, echocardiography. This will delineate anatomy, and this is the mainstay of diagnostic investigation. So management, how do you manage? Children with significant ASD, that is large enough to cause right ventricular dilatation. So small, usually I think they will wait and watch. For large defects, which will cause right ventricular dilatation and can lead to heart failure. So all the left to right shunts are known for heart failure. Okay, large left to right shunts. So children with significant ASD, large enough to cause right ventricular dilatation, will require treatment. For secondum ASD, this is by cardiac catheterization with insertion of an occlusion device. I showed you the occlusion device in the picture. So they will just do the cardiac catheterization with insertion of an occlusion device. But for partial AVSD, surgical correction is required. Okay. Treatment is usually undertaken at about 3 to 5 years of age in order to prevent right heart failure and arrhythmias in later life. So for ASD, the preferred time you can remember as 3 to 5 years. And they will go for correction only for the large ASD, which causes significant like heart failure or right ventricular dilatation. And the preferred is the cardiac catheterization with occlusion device. and about 3 to 5 years of age is the time. But for partial AVSD, they should go for surgical repair. So any questions in ASD before we go to VSD? Because VSD, we know that it's the commonest congenital heart disease. Okay, now VSD. Again, we should know that VSD, you have what? VSD, you have mild, moderate, and large. It can be small VSD, it can be moderate VSD, and it can be large VSD. Usually small and moderate, I think it is just wait and watch, like we saw in that case. At 18 months of age, at 5 weeks of age, the child presented with heart failure. She was maintained with anti-failure treatment, and at 18 months it closed. Okay, but for large VSD, you will not wait, you have to correct it. Okay, otherwise there is the child may go into Eisenmenger syndrome. So again, you can see the picture here, ventricular septal defect. So like this, you will have the VSD here. So what's happening here? From the left ventricle, the blood is increased flow to the right ventricle. So again, in the chest X-ray picture, what happens? Increased flow to the pulmonary arteries, right? So you will have dilated pulmonary arteries, cardiomegaly, you will have dilated pulmonary arteries and increased pulmonary vascular markings, or even you can say pulmonary edema. This will, but in small VSD, maybe the ECG is normal and even the chest X-ray is normal. So here, this is the chest X-ray findings: enlarged heart, enlarged pulmonary arteries, increased pulmonary vascular markings from pulmonary edema. Now the ECG findings. So inverted T wave, if there is inverted T wave in V1, it is normal, okay, no pulmonary hypertension. So if there is upright T wave in the V1, it includes pulmonary hypertension. So these patients can slowly, as the more and more blood flows into the pulmonary arteries, they can go into pulmonary hypertension. So how the ECG will guide you that they are developing pulmonary hypertension is the upright T wave in V1. Okay, this is the upright T wave in V1. Normally it will be inverted in V1. When you see upright, you have to think that there are some chances of pulmonary hypertension. At the same time, you can also have the ventricular hypertrophy here, because more blood is going here, right? And also at the same time, it goes to the lungs and more blood is also received by this left atrium and left ventricle. So both biventricular hypertrophy you can see in these patients. Okay, so ultimately it will be cardiomegaly. So this is the ventricular septal defect, septal defect showing right to left shunt, and murmur and chest radiograph and ECG. Murmur, we all know it's a pansystolic murmur. So you're hearing throughout. So here VSDs are common, accounting for 30% of all cases of congenital heart disease. There is a defect anywhere in the ventricular septum, we should know this. Perimembranous, that is adjacent to tricuspid valve here, okay, or in the muscular, completely surrounded by muscle. We know that here the VSD we will have usually like this. here I think the ventricular septal defect is membranous and muscular. I think 1/3 of the, I think as I remember, 1/3 is made of the membranous and 2/3 by the muscular. So the defect can be here perimembranous or the muscular also. This is most conveniently considered according to the size of the lesion. So again, small VSD. These are smaller than aortic valve in diameter, perhaps 3 millimeters. Okay, on very small, like 3 millimeters and even smaller than the aortic valve. They are asymptomatic. So VSDs can be asymptomatic also. You hear loud. The smaller the defect, the louder the sound you hear. Loud murmur implies smaller defect. Okay, loud pansystolic murmur in the lower left sternal edge. And also quite pulmonary second heart sound. We read that whenever the flow through this is more, you can have accentuated second heart sound. But in the small defects, the flow will not be more. So it can be just quiet. So you see, this everything will be normal in small. Chest radiograph normal, ECG normal, echocardiograph demonstrates beside anatomy of the defect. It is possible to assess its hemodynamic effects using Doppler echocardiography. You can also do the Doppler to see the pressure gradient across the lesion. Okay, and usually they will have no pulmonary hypertension. The simple is no increased flow, only loud murmur you hear. These lesions will close spontaneously. This is ascertained by disappearance of the murmur with normal ECG and followed by the pediatrician or pediatric cardiologist by normal echocardiogram. So just you will follow the patient only. Well, VSD is present. Oh yeah, this is very important point here. You are not intervening the patient, but education of the patient is very important. While VSD is present, prevention of bacterial endocarditis by maintaining good dental hygiene and avoiding body piercing and tattoos. So you have to tell the parents that you will observe the child for closure of the VSD, but at the same time, you should educate them about the occurrence of bacterial endocarditis in this patient. So you will tell them to maintain good dental hygiene and also to avoid body piercing and tattooing. Very important point, this one. Okay, but in large VSD, what do you do? This tends to be of the same size or bigger than the aortic valve. So 3 mm, usually small will be 3 mm, more than that it will be large. Symptoms: heart failure with breathlessness and faltering growth after 1 week old. Recurrent chest infections. Due to increased blood flow to the lungs, you will also have recurrent chest infections. So you will have the features of heart failure: tachypnea, tachycardia, enlarged liver, active precardium, pansystolic murmur. Okay. And also it can be a flow murmur. As I told you, increased blood is received in the left atrium also. So apical mid-diastolic murmur, an increased flow across the mitral valve after blood has circulated through the lungs. And also you can have loud pulmonary second heart sound. As the pulmonary hypertension begins, you will also hear loud P2, accentuated P2. So investigations here will be, again, we read about the chest radiograph. As I told you, in ECG, you can also see biventricular hypertrophy, both the right ventricle and left ventricle. In turn, there is increased blood flow in both. So you'll have biventricular hypertrophy. Echocardiography demonstrates the anatomy of defect, hemodynamic effects across the high pulmonary pressure. Management is very important here because these children will not be asymptomatic. They will have heart failure. You have to give diuretics and ACE inhibitors and follow for closure of the defect as soon as possible. So drug therapy for heart failure is with diuretics, often combined with captopril. Additional calorie input is required. There is always high pulmonary pressure in children with large VSD and left to right shunt. which will ultimately lead to irreversible damage to pulmonary capillary blood. This is Eisenmenger's. To prevent this, what is the time of surgery here? 3 months to 6 months. So the time of surgery in VSD is 3 to 6 months. In order to manage heart failure and faltering growth, prevent permanent lung damage from pulmonary hypertension and high blood flow. So in patent ductus arteriosus, again, you will hear a continuous murmur like this. Okay, the murmur will be continuous throughout. And again, the same thing, more blood flow to the lungs. So you will have cardiomegaly, enlarged pulmonary arteries and increased pulmonary vasculature. ECG can be normal, but since again there is increased blood flow to the lungs and in turn it will come back to the left heart. Okay, so you can have left ventricular hypertrophy, and also whenever the pulmonary hypertension develops, you can have right ventricular hypertrophy. So here also you can see biventricular hypertrophy in turn. Okay, to start with, what happens here in patent ductus arteriosus, if you understand what is happening, you will remember the ECG and also the chest X-ray. So this is left, this is right. Mike. So normally the pressure of the aorta is more than the pressure in the pulmonary arteries. So you will have left to right shunt. Here the more shunting will happen. So more blood will go to the lungs. So what happens, since more blood will go to the lungs, you will have enlarged pulmonary arteries and increased pulmonary vasculature. So in turn, what happens, from the lungs, the blood will come back to the left atrium and then the left ventricle. So again, there will be left ventricular enlargement. As the more and more blood is shunted to the pulmonary artery, there will be pulmonary artery hypertension. So this will cause right ventricular hypertension. So to start with, they may have left ventricular, then right ventricular. So they will have biventricular hypertrophy. Okay, this is one thing. And this is about the ECG and chest X-ray. So ECG can be normal, or they can have left ventricular and right ventricular hypertrophy. Okay, so to start with, they will have left ventricular. Later they can go with both, then it becomes biventricular. Then what happens here? How is the correction? Correction, we all know that we will try to close with brufen, ibuprofen, and sometimes paracetamol as well. If the medical management is failed, you will go for the surgical management. So this is D. D is the picture, a persistent ductus arteriosus visualized by angiography. So this is the aorta, this is the aorta, and this is the pulmonary artery. This is the PDA. Okay, you can see there is a connection here, PDA. This is how they are checking. This is by angiography. This is the coil. Okay, coil is used to close the duct. It is how they are doing by catheterization. I think it is passed through a catheter via femoral artery or vein. So from the femoral artery, the catheter is passed. Here it is shown. Okay, this is the coil they used to close. It will be passed from femoral artery or vein, and then angiogram to show the coil in the duct. This is the coil which they have used to close the patent ductus arteriosus. So if you remember this picture, you can remember the whole thing to answer most of the points. Okay. Clinical features and all we know. I'll just read only the investigation and management part. Chest radiography and ECG usually normal, but if PDA is large and symptomatic features on chest radiograph are indistinguishable from those seen in patient with large VSD. So large VSD and PDA will present in the same way because it is large left to right shunt. However, the duct is readily identified on echocardiography. Echocardiography will give you the picture. Management. Closure is recommended to abolish lifelong risk of bacterial endocarditis and pulmonary vascular disease. Like large VSD, these patients can also go into pulmonary hypertension and irreversible shunting. So closure with a coil or occlusion device is introduced via cardiac catheter, ideally at about the age of 1 year. So for large VSD, we said 3 to 6 months. Here they are telling up to the age of 1 year. Occasionally, surgical ligation is required. So this is first medical management. If failed, they can go for this coil occlusion. Okay, closure with a coil occlusion device. If still failed, they will go for surgical ligation. Next, we came right to left shunts. Most common is the tetralogy of Fallot, which can come in the exam, and transposition of great arteries. So in general, you should know the management of a cyanosed neonate. What do you do? Again, the prostaglandin will come here. So always the child is cyanosed. You see the child is blue and the oxygen saturation will be less than 94%. So here you'll start with airway breathing circulation with mechanical ventilation if necessary. So this will be in your mind. So the first thing what you will do, start prostaglandin E infusion, 5 nanogram per kg per minute. Most infants with cyanotic heart disease presenting in first few days of life are duct dependent. So infants presenting with cyanotic heart disease in first few days of life, they are duct dependent. Like the other which presented with shock and pale, it was from left heart outflow tract. This will be usually right heart outflow tract. So what happens here? There is reduced mixing between the pink oxygenated blood returning from lungs and the blue oxygenated blood from the body. So maintenance of ductal patency is the key to early survival of these infants. Observe the potential side effects of prostaglandin. Here he has given apnea, jitteriness, seizures, flushing, vasodilatation, and hypotension. So whenever you give prostaglandin, observe the baby, very important. So what happens here in the tetralogy of Fallot, there is right ventricular outflow tract obstruction. So the right ventricular outflow tract obstruction will result in blood flowing from right to left across the, so in VSD, what happens? The blood starts flowing from right to left. And also what happens? This is the murmur and chest radiograph. So what happens here? There is here, till now we discussed that there is pulmonary edema, increased pulmonary, but here it will be opposite. There will be pulmonary oligemia. The reason here is reduced blood flow is entering into the pulmonary artery. Okay, so what is happening here? Small heart, up tilted apex. We all know that it is described as boot shaped heart, and pulmonary artery bay. This is the arrow. And oligemic lung fields. You'll have less blood flow to the lungs, so oligemic lung fields. Here, you know, this, even the pulmonary artery will not be like in the normal heart. And check some other heart. You see the width of the pulmonary artery here. Okay, it will not be like that here. It's very small also. Okay, so you can see pulmonary artery bay and oligemic lung fields. So since here there will be right ventricular hypertrophy. Since there is right ventricular hypertrophy, in the ECG you will see features of right ventricular hypertrophy. One is the upright T wave in V1 and pure R wave in V1. Usually what happens in right ventricular hypertrophy is tall R waves in V1. Okay, they will be tall R waves in V1, and also you will also see the upright T wave in V1. Okay, upright T wave in V1 with pure R wave, no S wave, he is telling. But if you don't remember that also, it's okay, but you have to tell that there will be tall R wave in V1 and also upright T waves. Okay, this is very important here. A tetralogy of Fallot is a very common case and you should know it in and out. So the four features we see is the large VSD. Then we see overriding aorta with respect to ventricular septum. Then subpulmonic stenosis causing right ventricular outflow tract obstruction and right ventricular hypertrophy as a result. So all these outflow tract obstruction, overriding aorta with respect to ventricular septum, and large VSD. We can see in this picture all. This is the large VSD. This is the overriding aorta. This is, they can have subpulmonic stenosis here. Okay, and in turn it will cause right ventricular hypertrophy. Okay. So symptoms here, most are diagnosed antenatally. Okay, following the identification of a murmur in the first, they can be diagnosed antenatally by the anomaly scan at 18 weeks to 20 weeks, or there can be identification of a murmur in first 2 months of life. Cyanosis at this stage may not be obvious, although few present with severe cyanosis in first few days of life. Even severe cyanosis in first few days of life can occur in severe tetralogy of Fallot. There is something called severe TOF. Otherwise, they can present late. Okay, so usually you can hear a murmur at two months of age. Okay, and some children will present in the neonatal or antenatally. And you should know about the hypercyanotic spells. Okay, severe cyanosis, hypercyanotic swells, squatting and exercise developing in late infancy is now rare in high income countries, but still common. Okay, where necessary for pediatric cardiac services. We can read about the cyanotic cells later, mainly how this child presents and what are the investigations you do is very important here. So the signs, you can have clubbing of fingers and toes will develop in older children. You will have a loud, harsh. Since here there is stenosis, you will have loud, harsh ejection systolic murmur at the left sternal edge from day 1 of life. With increasing right ventricular outflow tract obstruction, which is predominantly muscular below the pulmonary valve, the murmur will shorten and cyanosis will increase. So in the beginning, they will have loud, harsh ejection systolic murmur. As they grow, the murmur will reduce and the cyanosis will increase, because here it is not the valve that is stenosed. What he is telling, it is with increase in the right ventricular outflow tract obstruction, which is predominantly muscular below the pulmonary valve. So we read about the chest radiograph, how it looks. This is the boot-shaped heart, and there will be an pulmonary artery bay. Okay, this is the pulmonary artery bay. You have to tell what is it. Concavity on the left heart border, where convex shaped main pulmonary artery and right ventricular outflow tract would normally be profiled. So the concavity, you see concavity here because the growth is not good. The convex shape, which is normally seen in the pulmonary artery and right ventricular outflow tract, is not seen here. Okay, that this is called pulmonary artery bay. This is the reason why you see the heart like boot shape and reduced blood flow, which we read. And you know that there is right ventricular hypertrophy. So you will tell what tall R waves in V1 and also upright T waves. Echocardiography, this will demonstrate cardinal features, but cardiac catheterization or MRI scan may be required to show detailed anatomy of the coronary arteries if not seen. This is not important for us, but we have to tell that echocardiography will demonstrate the clear TOF. Management is very important. See, not every child with TOF, you see both this lateral thoracotomy scar and central sternotomy scar. Not everyone. Some children at 6 months of age, they will be taken for definitive surgery at once. Not every child with the TOF will have lateral thoracotomy scar. Okay. See, initial management is medical with definitive surgery around 6 months of age. At the age of 6 months, we will do definitive surgery. It involves what do you do? Closing of VSD, relieving the right ventricular outflow tract obstruction, sometimes with an artificial patch which extends across the pulmonary valve. So you are correcting all these 4 problems here they have. Right ventricular hypertrophy, once you correct the problems, will resolve. So here what happens? You will close the VSD and you will correct the pulmonary artery stenosis. So overriding aorta, if you close the VSD properly, the aorta will be located for the left side. Okay, so this is not the problem. So the pulmonary artery will be, usually there is no problem in the valve here. The problem is below the valve, which is the muscular defect here. Okay, so what they are doing here, relieving the right ventricular outflow tract obstruction, sometimes with an artificial patch which extends across the pulmonary valve. So there will be an artificial patch they put, and it can extend across the pulmonary valve, but they will relieve this muscular obstruction which is present below the pulmonary valve. Okay, so you should know only that surgery will be done and you will refer to the cardiologist, and definitive surgery is at the 6 months of age. Okay, so what is the other things? There are some children, okay, up to 6 months you will do some medical management to them, but there are some children who are cyanosed in early neonatal period requiring a shunt to increase pulmonary blood flow. Means up to 6 months you cannot wait, they are cyanosed in the early neonatal period. You cannot wait up to 6 months to do definitive surgery at once, because they are cyanosed in the early neonatal period. So you have to give them a shunt. There comes the modified BT shunt now. Okay, that is the lateral thoracotomy scar we see. This is usually done by surgical placement of an artificial tube between the subclavian artery and the pulmonary artery. So let's draw now. So if this is the, because there is right ventricular outflow tract obstruction, the pulmonary artery is not receiving enough blood. This is the reason of cyanosis here. So what they are doing with the subclavian artery, this is the subclavian artery you have, they are connecting a tube here. Okay, so what happens here? An artificial tube between the subclavian artery and the pulmonary artery. And this is the modified Blalock-Taussig shunt, BT shunt. Or by balloon dilatation or stent insertion in the right ventricular outflow tract obstruction. So before going to the definitive surgery, which involves the closure of VSD and release of the right ventricular outflow tract obstruction by using an artificial patch, if the child is cyanosed in the neonatal period, you will consider BT shunt. Such patients, you can see both median sternotomy scar of definitive surgery at 6 months and BT shunt scar lateral thoracotomy before the age of 6 months. But some children, they can have only one scar. At that time, you have to think that he was done definitive surgery at once at the age of 6 months. Okay, so this is the thing here. Now, another important management in these children we should know is the hypercyanotic spells. So hypercyanotic spells are usually self-limiting and followed by a period of sleep. If prolonged beyond about 15 minutes, then should give prompt treatment according to need. Okay. So hypercyanotic spells, usually if it is less than 15 minutes after a prolonged sleep, they no need to do anything. But if it is prolonged beyond 15 minutes, you have to give the prompt treatment. So one is the sedation and pain relief. Always consider morphine. Okay, before that, that knee chest position is very important here. Okay, knee chest position, then morphine. You can consider intravenous propranolol or an alpha adrenoreceptor agonist, which probably works both as peripheral vasoconstrictor by relieving subpulmonary muscular obstruction. Okay, and as we know that here there is subpulmonary muscular obstruction here. The right flow out is muscular. So this propranolol, what it will do, it will release this muscular obstruction as well as the peripheral vasoconstriction. It will work both as peripheral vasoconstrictor and also relieves this muscle obstruction. So you can remember beta 2 blockers. First thing is morphine. Next thing is the beta 2 blocker, that is the propranolol. Next is IV fluid administration. Then bicarbonate to correct acidosis. Muscle paralysis and artificial ventilation in order to reduce metabolic oxygen demand. This is last resort. I think most of them will improve with morphine. First is the position, knee chest position. Then you will give morphine. Then you will give propranolol. Propranolol has two actions here. One is the peripheral vasoconstriction. So in turn, it will reduce the blood to the, blood coming to the right heart. And at the same time, it will relax the muscle. That is the subpulmonary muscular obstruction will be relaxed. In that way, the propranolol will help. The third thing is the IV fluid. If there is acidosis, you'll go for bicarbonate. And I think muscle paralysis and artificial ventilation as a last resort, you can keep it. Yes, there is a good comment here. Oxygen is missing. Yes. First thing is the knee chest position. High flow oxygen with a face mask. Very important. Okay. Even when you are outside, if it is outside also, there will be you will put the you should teach also the parents about this knee chest position. And even the outside or the ambulance, when they bring, they should give high flow oxygen, that is 15 liter through the face mask. And IV fluids all as well, and propranolol should be considered, and bicarbonate. And also I think there is one more drug, I am not remembering at the moment.
I think
Phenylephrine.
phenylephrine, systemic vasoconstrictor, phenylephrine, I think.
Yeah, noradrenaline and phenylephrine.
Yeah.
Anyways, there should be an action of peripheral vasoconstriction as well. That is, propranolol will work for both. But at the same time, if in resistant cases, you can go for this phenylephrine. Before this last, what he has told, this muscle paralysis, I think it's very rare. This one don't tell. You can tell all this before, because
Actually, norepinephrine we are not using here because
phenylephrine.
norepinephrine can cause vasodilation peripherally. That reduces the systemic resistance, and it will help exaggerate this one tough.
So
Oh, you are saying wrong.
Phenylephrine.
Noradrenaline is a vasoconstrictor peripheral, not a vasodilator.
Okay. You are right.
No, here I know, I have read in some places phenylephrine or noradrenaline they are using. There is one this for
Yeah, phenylephrine or no adrenaline.
Okay, this is the management of cyanotic spell. This is from one of the NHS websites. So suspected cyanotic spell, what do? Child with tetralogy of Fallot, inconsolable, small children can present to you with inconsolable crying, increased cyanosis, tachycardia or tachypnea, low intensity or absent murmur. So during cyanotic spell, there won't be any flow through this pulmonary artery. Okay. So you can have low intensity or absent murmur as well, because what happens, the muscle, the sub pulmonary valve muscular, it will get contracted. So you may not have, you may have low intensity or absent murmur, and the child has increased cyanosis, inconsolable cry, tachycardia, tachypnea. In that time, treat as emergency. Inform on-call ICU and cardiology teams immediately. Place the child in knee chest position with pressure on femorals. Okay, I think this pressure on femorals will also reduce the flow to the heart, right? Okay, so place the child in knee chest position with pressure on femorals. Then you will give high flow oxygen, very important. Non-rebreathable mask. You can also mention 15 liters. Okay, then give morphine. Morphine is given, if you want to remember the dose, 50 micrograms per kg. Then if spell resolves, stop the treatment. If not, you will repeat morphine. Then after morphine, fluid bolus, 10 ml per kg. Then still, if it is continuing, you will consider beta blockers. If not on beta blockers, you will consider beta blockers. Okay, that is propranolol. If no response to treatment, so the last will be the phenylephrine. Arrange PICU admission. These are the steps you should tell. First is the knee chest position, then high flow oxygen, give morphine, not resolved. You can consider second dose morphine and fluid bolus. Still not resolved, you can consider beta blocker, that is propranolol usually, if the child is not on regular beta blocker. Okay, still no response to treatment, you will go for phenylephrine or even noradrenaline. I think just names are enough, no need to remember the doses and the steps. Okay, now we have to continue with the transposition of great arteries. Just 2 minutes, we will continue. So can you see the picture of transposition of great arteries here? It's very clear, okay? You can remember better. So this is the right heart and this is the left heart. Now what has happened here? Transposition. The aorta is arising from the right heart and the pulmonary artery is arising from the left heart. And also there is a VSD here. If there is a VSD and mixing of blood, it is very good for us. But if there is no VSD, you will make an VSD here. Okay. So in again, in a cyanosed neonate, one of the DD for us is the transposition of great arteries.
We'll make ASD. ASD. Yeah. Yeah.
Sorry, ASD. Yeah. Thank you.
No, it's okay.
So in the cyanosed neonate, the differential is the transposition of great artery. So here, this is the picture of how they are doing. They are making an opening between the two atrium. So this point is very important. The transposition of great arteries, establishing a prostaglandin infusion to maintain patency of ductus arteriosus is essential. Balloon atrial septostomy. This is the balloon atrial septostomy, which may be life-saving. Okay. Next, you see the chest X-ray, very important here. Egg on side appearance. Okay, this is the egg on side appearance of the chest X-ray. Narrow pedicle. Normally what happens from where the aorta rises, it is not rising. So here you are getting a narrow pedicle here. This is narrow. Okay, so narrow pedicle, egg on side appearance, cardiac, egg on side appearance, cardiac contour. So increased pulmonary vascular markings. Okay, so there will be increased pulmonary vascular markings. ECG usually normal neonatal pattern because it will present in the neonatal period immediately afterwards. You don't see any changes in the ECG. Mainly you can see the chest X-ray only. This is the narrow pedicle you have here, and you will have egg on the side appearance, and you will have increased vascular markings. Okay. So it's very clear whenever you draw, also for the drawing, you should draw clearly that the aorta is arising from the right heart. And so the whole body is receiving the blood from the right ventricle, which is the deoxygenated blood. And the oxygenated blood is going to the lungs. And coming again, the same oxygenated blood is coming back to your right atrium. So you need here mixing, because when the oxygenated blood mixes with the deoxygenated, then only some amount the baby can survive or breathe or something like this. So if there is no mixing, the palliative procedure here will be the balloon atrial septostomy. Okay. So let's go to the here for the murmur, variable systolic murmur you can have, and single second sound you can have. So what are the signs and symptoms the child will present? Cyanosis is the predominant symptom. It may be profound and life-threatening. If not detected antenatally, presentation is usually on day 2 of life, when duct closure leads to same like what happened before. Either by the antenatal scan, it has to be detected, and planned birth of the child in the tertiary cardiac center should be done. Or if it is not detected, when the duct closure happens on the 2nd day of life, the child will present to you. Presentation usually in the day 2 of life when duct closure leads to marked reduction in mixing of the desaturated, and there won't be any mixing when the duct closes. Cyanosis will be less severe and presentation delayed if there is more mixing of blood from associated anomalies. If there is an ASD, it is good, they can present late. If there is no ASD, only the child is dependent on patent ductus arteriosus, so they can present on day 2 of life when there is closure of the duct. So physical signs is cyanosis, always present. Second heart sound should be loud and single. Because second heart sound will be usually single and it will be loud. Usually no murmur, but maybe systolic murmur from increased flow or stenosis with left ventricular outflow tract obstruction. So usually they may not have any murmur, or also they can have a systolic murmur from increased flow or stenosis in the left ventricular outflow tract obstruction. Maybe if they have any associated, but I don't know whether the murmur from the ASD will be heard or not. I am not sure. Okay, he hasn't given about it. Anyone has any idea about it? Do you hear any murmur in TGA?
No.
Here he has written variable.
Usually TJ no murmur. Usually TJ no murmur.
No murmur. Okay. What about this ASD? In this ASD present, you don't hear any
But
murmur.
there will not be any gradient in between the ASD.
Okay.
So,
Okay. So usually no murmur. Next is the investigations. This may reveal classic finding of the egg on side appearance. Appearance of the cardiac shadow due to antero-posterior relationship of the great vessels, narrow vascular pedicle and hypertrophied right ventricle respectively. So the reason here is the antero-posterior relationship of the great vessels, because they are mispositioned, ultimately it will come as a narrow pedicle. Okay, and also there can be hypertrophy of the right ventricle, because here now the right ventricle is taking the task of left ventricle with because the aorta is in right ventricle and it is pumping the blood to the whole body. So they may have what? Right ventricular hypertrophy. This is the reason. Narrow upper mediastinum with egg on side appearance. Increased pulmonary vascular markings are common due to increased pulmonary blood flow. Again, any cyanosed neonate, even if the cyanosed neonate comes, this is the management you will say. In sick cyanosed neonate, the key is to improve mixing. So your plan is to mixing. Maintenance of the patency of ductus arteriosus with prostaglandin infusion is mandatory. A balloon atrial septostomy may be life-saving procedure which needs to be performed in 20% of those with TGA. A catheter with an inflatable balloon at its tip is passed through the umbilical or the femoral vein. Here, since he's neonate, you have a chance to pass through the umbilical also. So at its tip is passed through the umbilical or femoral vein, then through the right atrium and the foramen ovale, and the balloon is inflated within the left atrium and then pulled back through the atrial septum. This tears the atrial septum and renders the flap valve of the foramen ovale incompetent. So making the flap valve of the foramen ovale incompetent will help in mixing, and so allows the mixing of the systemic and pulmonary venous blood in the atrium. All patients with TGA will require an operation, which is usually arterial switch procedure in the neonatal period. So first thing, maintaining the patent ductus arteriosus with prostaglandin infusion. If there is no atrial septal defect, you will go for balloon atrial septostomy. These two will be palliative for these patients. Then a definitive surgery of arterial switch procedure in the neonatal period will be done. In this operation performed in the first few days of life, the pulmonary and artery are transected above the arterial valves and switched over. In addition, the coronary arteries have to be transferred across the new aorta. More complex forms of transfusion will need alternative operations. So above the valves here, just we have to remember simple things only, no need more. Just above the valves, they will be cut and they will be transected to their positions. This will come here and this will go there. This is the arterial switch operation. And also the coronary transferring the coronary arteries should also be taken care. This is what he is telling. The coronary arteries have to be transferred across the new aorta. So this is what he said. A balloon will be passed from the femoral artery or the umbilical femoral vein or the umbilical vein. Then it will enter the right atrium. Through the foramen oval, it will enter the left atrium. Then it will be pulled back. So the foramen oval will be done incompetent here and there will be mixing. A balloon about 2 ml is pulled through the atrial septum from the left atrium to the right atrium in order to increase the size of atrial defect. This is done with echocardiographic guidance. Okay, and also under the guidance of echocardiogram showing balloon in the left atrium. This figure. Okay, this B is balloon, I think. Echocardiogram showing balloon in the left atrium. Okay, balloon has been pulled through the atrial septum and is now in right atrium. So from here they pulled it this side. Okay, that's how they do the balloon atrial septostomy. So these are the commonest congenital cyanotic congenital heart disease you see. So tetralogy of Fallot, loud murmur in the upper left sternal edge. Okay. So you see clubbing of fingers and toes in older children and they can present with hypercyanotic spells. Even the infants with inconsolable cry, blue, they can be in hypercyanotic spells. You have to treat them. So definitive management, as I told you, 6 months at 6 months. But before that, if the children have the cyanosis and repeated cyanotic spells, palliative surgery with modified BT shunt can be considered. Then transposition of great arteries, usually they present with neonatal cyanosis and no murmur here. Just remember no murmur. Even if the ASD is present, it is insignificant. Here prostaglandin infusion, balloon atrial septostomy, arterial switch operation, very important. Eisenmenger, no murmur. The heart failure in the Eisenmenger will be right heart, okay, and cyanosed and clubbing. Medication plays very important role and the ultimate treatment is heart-lung transplantation. So now we finished the right to left shunts, that is TOF and transposition of great arteries. We will go to common mixing, that is blue and breathless. So previously with the AASD, we read about partial AVSD. Now here they are talking about complete AVSD. Okay, atrioventricular septal defect, complete atrioventricular septal defect with a common atrioventricular valve. With a common atrioventricular valve between the large atrial and ventricular component to atrioventricular septal defect. So you can see here, this is the defect here and also here. Okay, and I think this is the valve which is common, and it will be flowing, but I don't know what he has shown on the left side here. This one, he's telling that complete atrioventricular septal defect with a common atrioventricular valve between the large atrial and ventricular component to the atrioventricular septal defect. Maybe this is what he is telling, the common valve, but I'm not sure what on this right side. We can go through the notes to know. So one thing, some important points you should know about the AVSD. This is most often seen in children with Down syndrome. Okay, a complete AVSD is the defect in the middle of the heart with single 5 leaflet common valve. So you will not have two separate valves like tricuspid valve, mitral valve and tricuspid valve. You will have a single big valve. Like total we have 5 valves, right? 2 for mitral and 3 for tricuspid. So you will have a single big valve with 5 cusps, he is telling, 5 leaflets. 1, 2, 3, 4, 5. Okay, so complete AVSD is a defect in the middle of the heart with single 5 leaflet common valve between the atrial and ventricles, which stretches across the entire atrioventricular junction and tends to leak. Okay, as there is large defect, there is high pulmonary arterial pressure. As we know that the defect is very large, more and more blood is entering the pulmonary artery, high pulmonary arterial pressure. So presentation, antenatal ultrasound screening, by that you will know. Cyanosis at birth or heart failure, because this is with mixing. So you can have both presentation. Both with cyanosis or with heart failure, both. Cyanosis at birth or heart failure at 2 to 3 weeks of life. Not like VSD. VSD usually presents with heart failure. The TOF will usually present with cyanosis. Now this condition comes in common mixing. So the presentation can be either cyanosis and heart failure or both. So no murmur heard. It's a very large defect. As we read before, in a small VSD, smaller the VSD, the louder the murmur heard. So maybe you may not hear any murmur, no murmur heard, but the lesion is detected on routine echocardiography screening in a newborn with Down's syndrome. Maybe antenatal ultrasound scanning or routine echocardiographic scanning of the neonate with Down syndrome you will get, or the presentation, cyanosis and heart failure. There is always superior axis on ECG. I told you even when we were reading partial AVSD, always remember that there is superior axis on ECG. Management, treatment of heart failure medically as for large AVSD, that is diuretics and captopril. Surgical repair, you will consider here 3 to 6 months of age, like in large AVSD. But here at as early as 3 months. Okay. So next is the tricuspid atresia. So complex congenital heart disease, it is difficult to generalize about these conditions. So you cannot categorize under some general condition. Tricuspid atresia, mitral atresia, double inlet left ventricle, common atrial arterial trunk, truncus arteriosus, because their main presenting feature depends on whether cyanosis or heart failure is more predominant. Tricuspid atresia is the most common. So these are common mixing conditions. They have included AVSD and tricuspid atresia. So they can present to you either in cyanosis or in the heart failure. So here you can see the picture for tricuspid atresia. Okay. That means you see the right ventricle is very small. In tricuspid atresia, there is only one effective ventricle because of the complete absence of the tricuspid valve. So here you see, we don't see the tricuspid valve at all. This is the right atrium, which is separate here. There is no connection between right atrium and ventricle as tricuspid valve. Directly the right ventricle, which is very small, is connecting to the pulmonary artery here. See, in tricuspid atresia, there is only one effective ventricle because of complete absence of the tricuspid valve. So what happens, as I told you, it's a common mixing. So the presentation can be with cyanosis or heart failure. Presentation is with cyanosis in the newborn period if duct dependent, or child may be well at birth and become cyanosed or breathless. So management, again, you will go for early palliation, as with all common mixing complex disease, is performed to maintain secure supply of blood to the lungs at low pressure. So again, what happens here, that the right ventricle is very small. So no sufficient blood will be going to the lungs. So the patency of the ductus arteriosus is very important. A BT shunt insertion between the subclavian and pulmonary arteries in children who are severely cyanosed. This is the palliative procedure. Other thing is the pulmonary banding operation to reduce pulmonary blood flow if breathless. So depending upon the presentation, in the cyanotic neonates, where the blood flow is very less to the pulmonary arteries, they will do BT shunt. But in cases presenting with heart failure and shortness of breath, pulmonary artery banding procedure. So your palliative procedure depends upon the presentation of the child. Okay, that's why here they are coming under the name complex congenital heart disease. They can present to you with cyanosis, they can present to you with breathlessness, shortness of breath, and heart failure. So if severely cyanosed, BT shunt to increase blood flow to the lungs. If more blood is flowing to the lungs, then you will do pulmonary artery banding operation. Complete corrective surgery is not possible with most, as there is often only one effective functioning ventricle. Okay, as we say, the other ventricle is not functioning here, the right ventricle, and there is no tricuspid valve at all. So definitive corrective surgery is difficult. Okay, palliation is performed. Glen and hemifontan operation connecting the superior vena cava to the pulmonary artery. So what they are doing, this superior vena cava here, this superior vena cava, they will connect it to the pulmonary artery. Doing two sets of operation here. One is at 6 months of age. Both, you have to just remember that both vena cavas are connected. Okay. In the first operation, they are connecting superior vena cava to the pulmonary artery. It is at 6 months of age. Then in the, this is Glen. Then in Fontan, that is, this is called total cavopulmonary, because both the vena cavas, they are connecting to the pulmonary artery. Okay. To connect inferior vena cava to the pulmonary artery at 3 to 5 years of age. So 2-stage operations is done here. In the first stage at 6 months of age, superior vena cava is connected. In the second, inferior vena cava is connected. Then it becomes total cavopulmonary connection. Okay, but before that, you should know 2 palliative procedures according to the presentation of the child. That is either BT shunt or pulmonary artery banding. Thus, left ventricle drives blood around the body. The reason here to connect this both inferior and superior vena cava to the pulmonary artery is, this is now non-functional. This ventricle is very small, and this ventricle is pumping to the whole blood to the body through the aorta. So how you are supplying more blood to the pulmonary artery is by connecting directly this both superior and inferior vena cava to the pulmonary artery. This is the thing they are doing here. Thus, left ventricle drives blood around the body to systemic. Thus, left ventricle drives the body, blood around the body, and systemic venous pressure supplies blood to the lungs. So, as I told you, from the left ventricle, blood will go to whole body, and from the vena cava and inferior vena cava, it will go to pulmonary artery. The Fontan operation results in less than ideal functioning outcome, but has advantages of relieving cyanosis and removing long-term volume load on single functional ventricle. Okay, since you are connecting directly to this, now the blood is from the superior vena cava and inferior vena cava will go to the pulmonary artery. So the pressure on the single ventricle will be reduced. This is the purpose of the operation. So common mixing lesions you should know. AVSD, Down syndrome, they present with cyanosis or breathlessness both. A treatment of heart failure and surgical repair at 3 months of age for AVSD. Complex disorders, again cyanosis and breathlessness. You will start with palliative, either BT shunt or pulmonary artery banding. Then there is no definitive repair. Again, these repairs will help you. That is Glen. In the Glen, first you will connect only superior vena cava to pulmonary artery. Then in Fontan, inferior vena cava. So when you do Fontan, it will become total caval correction. Okay. So we all know in aortic stenosis what happens. There will be left ventricular hypertrophy. You can see here in the picture, it's very clear. You see, compared to right ventricle, you see here, there is left ventricular hypertrophy here. Okay, so what happens here? You will see left ventricular strain pattern. So in V6, normally we should have what? T wave, upright T wave, but here we have inverted T wave. This represents the left ventricular strain pattern. And also you will have tall R waves in V6, V5 and V6. You can have tall R waves and deep S waves in V1 and V2 both. Okay, V1 and V2, and tall R waves in V6. Here he has given, you see, tall R waves in V6 more than 45 mm total. If you see the measure it should be more than 45 mm tall. Indicates left ventricular hypertrophy. The strain is the inverted T wave in V6. Okay, and deep S waves in V2 and V1. This is very important. You should know this, left ventricular hypertrophy and aortic stenosis. Now the X-ray. Since we saw here there is left ventricular hypertrophy, prominent left ventricle, and also you see here this arrow, because there is a stenosis, you can have post-stenotic dilatation of the ascending aorta. Now as the aorta rises, now this is the left heart. When it arises from the heart, it will go like this, right? So it is coming towards the right side here. From the left, it is moving towards the right side here. So there can be post-stenotic dilatation here. Let me use some other color. Okay. You can have here what? Post-stenotic dilatation because of here there is stenosis. So this you can see here. This is the post-stenotic dilatation you can see here. Okay, so what is this? Prominent left ventricle, you can see cardiomegaly and post-stenotic dilatation of the ascending aorta. And we all know the murmur of the cardiac aortic stenosis and its radiation. It will be an ejection systolic murmur, okay, radiating to the carotids. Okay. So this is outflow tract obstruction in a well child. Where is the ECG and echocardiography? I should know. Let me read here. Management. So see ECG, left ventricular hypertrophy, chest radiograph, normal or prominent left ventricle with post-stenotic dilatation. This is the feature you see. In children with regular clinical and echocardiographic assessment is required in order to assess whether to intervene. Any child with aortic stenosis, you will follow them up when you want to intervene. So children with symptoms on exercise, suppose a child is coming to you and telling that on exertion, when he plays football or something, he has chest pain or shortness of breath. Children with symptoms on exercise or who have high resting pressure gradient. When the child is resting, the pressure gradient is high across the aortic valve, that is more than 64. So any aortic stenosis child, any aortic stenosis child presenting with symptoms, you will go for this balloon valvotomy. But even at rest, if their pressure gradient is more than 64 mm of Hg across the aortic valve, we'll go for balloon valvuloplasty. Okay, balloon dilatation in older children is generally safe and uncomplicated, but in neonates, this is much more difficult and dangerous. So this is for the older child. This is for the older child. Okay. Next, most neonates and children with significant aortic stenosis requiring treatment in the first year of life will eventually require aortic valve replacement. Early treatment is therefore palliative, directed towards delaying this as long as possible. So here there is a point which we have to understand in the treatment of aortic stenosis. if the child is older child, presenting to you with symptoms, or he has no symptoms, but when you do echocardiography, his pressure gradient is more than 64 mm of Hg across the valve, aortic valve, you will go for intervention. The intervention is balloon valvuloplasty or valvulotomy, sorry, balloon valvulotomy. That means you're opening, you're just dilating with a balloon and opening the valve, removing the stenosis. But in the neonates, what happens? You may do this balloon valvulotomy just to give them the time to grow. Ultimately, they have to go for aortic valve replacement. Most neonates and children with significant aortic valve stenosis requiring treatment in first few years of life will eventually require aortic valve replacement. So early treatment is therefore palliative. So whatever balloon valvotomy you're doing when they are small infants will be just palliative for them. Later, they may need to go into aortic valve replacement. Okay. Early treatment is therefore palliative and directed towards delaying this as long as possible. These points has to be remembered here. Next, again, pulmonary stenosis. See, we have to know the pulmonary stenosis in the TOF is not from the valve, it is from the subvalvular muscular lesion. Okay, but here this is the valvular pulmonary stenosis. So we will have a stenotic valve here. Okay. Again, we hear a ejection systolic murmur. Okay, in the left upper sternal edge. Okay, since there is stenosis, the less blood will enter into the less blood will enter into the pulmonary artery. You can also have soft or absent P2. Soft P2 can be there. Same thing in the aortic stenosis, we saw the post stenotic dilatation this side, but here you will see this side. So in pulmonary stenosis, you can have what? You can have right ventricular hypertrophy as well. Depending upon how long standing the condition is, you can have right ventricular hypertrophy and post stenotic dilatation of the pulmonary artery. So in the ECG, you will see right ventricular hypertrophy, that is tall R waves in V1 and also upright T wave. Upright T wave indicates right ventricular hypertrophy in children, and also they will have tall R wave. As we read there, I think it's more than 45 mm of Hg. Sorry, more than 45 millimeters.
Doctor, no, that was the criteria for left ventricular hypertrophy.
Not for right ventricle?
No. Right ventricular hypertrophy signifies if you find the R waves in the V1, because otherwise these are absent.
Normally, everyone will have R wave in V1. But
No. V1, no, because the passage of the current is opposite, so you will not able. There are no R waves in the V1. There are only S waves. As when you're just going to see how we are applying the leads, so you will able to know that okay, this is the direction of flow of the current. So V6 is more towards the heart. Okay, so that is why R waves you can find up.
Yeah, but
in the V6.
But there will be small and deep S waves, you mean?
Yes, in the V1, but as V2, V3, V4, V5, V6, you will get R waves, and depth of the S wave will be less.
Okay, yeah. We will see a normal ECG, then we'll get to know it's there. So here in the pulmonary stenosis, what happens? Most children are asymptomatic, but when the pressure gradient across the pulmonary valve on Doppler echocardiography becomes markedly increased. Here also he has given the same value and it should be markedly increased. Then 64, more than 64 mm of Hg, intervention will be required. Again here transcatheter balloon dilatation is the treatment of choice. So here you should know the physical signs. As I told you, ejection systolic murmur, thrill may be present, and an ejection click, because this is involves the valve. You can have an ejection click here. Then there can be a prominent right ventricular impulse or heave, because if there is right ventricular hypertrophy. So adult type coarctation of aorta, the child which will presented on the second day after the closure of the duct will be severe coarctation of aorta. But there is something called adult type coarctation of aorta, which you should know. I don't know here there is picture for it or not. Yeah, it is there. So here, this is the adult type coarctation of aorta. And here what happens? Ejection systolic murmur between the shoulder blades. Here he has shown the arrow. Where do you see? Behind, in the upper part between the shoulder blades. This is the position of the murmur you hear on the back. Okay. And because this is long standing, you can see the rib notching from aortic to aortic collateral arteries in young people and adults. So in the X-ray, rib notching can be seen because of the development of collaterals. Okay, because of the long standing problem. Again, any coarctation of aorta will have what? Left ventricular hypertrophy. So you see deep S waves in V2 and tall R waves in V6. So tall R waves in V6 more than 45 mm in total, and upright T wave indicate left ventricular hypertrophy. So here, whenever in V6 there is down going, it's like a left ventricular strain pattern. And also they can have some ST depressions also. There can be ST depression and T wave inversion. Also like an ischemic pattern as the strain pattern. Okay. Down going T wave suggests left ventricular strain or severe coarctation or hypertension. So you can have downgoing wave in V6. It will indicate three things for you: left ventricular strain, severe coarctation, or the child is developing hypertension. Or you can have also this tall R waves in V6, okay, which will be more than 45 mm tall. Whenever there is a downgoing T wave in V6, you have to think of the left ventricular strain. Okay, this is about the adult type. So what is the treatment you are giving? I think this came, adult type coarctation of aorta came in the exam for communication scenario recently. This uncommon lesion is not duct dependent. It gradually becomes severe over many years. It is much more common for coarctation to present in neonatal period. As we said, the duct dependent severe coarctation will present in the neonatal period. This will present late. Clinical features: asymptomatic systemic hypertension in the right arm. Okay. and ejection systolic murmur at the upper sternal edge. As I showed you, you will. Wait, this is which I'm reading. Is it this? Okay. Then collaterals heard with continuous murmur at the back. But he told between the shoulder blades, you can hear this murmur. Okay. And it can be an ejection systolic murmur. Then radiofemoral delay. This is due to blood bypassing the obstruction via collaterals in the chest wall, and hence pulse in the legs is delayed. Okay. There will be not absent femoral pulses. You can feel them, but it will be delayed. Radiofemoral delay. Chest radiograph, rib notching due to development of large collateral intercostal arteries running under the ribs posteriorly to bypass the obstruction. 3 sign with visible notch in the descending aorta at the site of coarctation. You can also see this sign of 3 like this. Okay. Then what is the thing? As we told, left ventricular hypertrophy. Same like in aortic stenosis, how the left ventricular hypertrophy. Management, when condition becomes severe and assessed by echocardiography, a stent may be inserted at cardiac catheter, sometimes surgical repair. So to start with, to open the coarctation, they will give the stent. And if later needed, surgery will be considered. So this is for the adult type coarctation of aorta. See here, the signs: aortic stenosis, murmur, upper right sternal edge and carotid thrill. Pulmonary stenosis, murmur, upper left sternal edge, no carotid thrill. Coarctation of aorta, systemic hypertension, radiofemoral delay. So here, coarctation, stent insertion and surgery for these both balloon dilatation. This is in a well child and when there is late presentation. So coarctation of aorta in the small child, they can present with the shock, sick baby with severe heart failure, shock, absent femoral pulses, metabolic acidosis, cardiomegaly, heart failure, shock. In such patients, as we said, palliative, they'll start with prostaglandin. And once the child is fine, they'll consider balloon dilatation in critical aortic stenosis, but in coarctation of aorta also they may consider dilatation. This is same for all sick patients with outflow tract obstruction. Surgical repair is performed as soon as after diagnosis. So interruption of aortic arch, you should know something about the DiGeorge syndrome, absent thymus, palatal defects, immunodeficiency, hypocalcemia. This is more common with it, and it will also present with the shock in the neonatal period. Needs to consider prostaglandin and then definitive surgery after resuscitation. See, for all these 3 conditions, coarctation of aorta, interruption, hypoplastic left heart syndrome, management will be maintain ABC, prostaglandin infusion. Okay. So hypoplastic left heart syndrome is very common. We should know about it. In this condition, there is underdevelopment of the entire left side of the heart. Okay, so here you can see the entire left side is underdeveloped and the mitral valve is small, atretic, and the left ventricle is also small. There is usually aortic valve atresia, like what was there in the tricuspid atresia. You had the small ventricle and tricuspid. Even here, the aortic valve atresia can be there. The ascending aorta is very small. You can see the ascending aorta is very small. And there is almost invariably coarctation of aorta. It will also have coarctation of aorta as well. So it's a complex congenital heart disease where there's a small left ventricle and also this aorta and coarctation of aorta. These children are usually detected antenatally at ultrasound screening. This allows for effective counseling and prevents the child from becoming sick after birth. They may be identified by oxygen saturation screening. If they do present after birth, they are the sickest of all neonates, presenting with duct-dependent systemic circulation. There is no flow through the left side of the heart, so ductal constriction leads to profound acidosis. Okay, and rapid cardiovascular collapse. There is weakness or absence of peripheral pulses in contrast to weak femoral pulse in coarctation of aorta. So in this case, all the peripheral pulses are weak. But in coarctation of aorta, you will have only femoral pulses are weak or absent. But here, all the peripheral pulses are weak and they will present in the sickest form. So the management of the condition consists difficult neonatal operation called Norwood procedure. Children who have complex lesions or are small for gestational age can undergo hybrid procedures that are combination of cardiac catheter and surgical operation. This is followed by further operation, Glenn or hemifonton at about 6 months of age. Same we read before. What is Glenn and hemifonton? Okay. They are doing the same procedures here. Okay, and also there is one Norwood procedure. But before, more than that, for us, we will be asked about the immediate management of the child. That is the maintaining ABC and prostaglandin infusion, or if you know antenatally, arranging them in a tertiary center, counseling the parents of the requirement of the heart surgery and resuscitation of the child and requirement of the heart surgery immediately after birth. So what he is telling, with who have complex lesions and small for gestational age, hybrid procedures will be done. There will be cardiac catheterization and surgical operation will be, all these things, maybe it will be palliative. Then they will go for Glenn and hemifonton at 6 months and 3 years of age. So I think cardiac arrhythmias is left, which can be read by themselves. Okay, who can tell what is the difference between the adult type coarctation of aorta and the severe coarctation of aorta in the neonate?
Adult type, can I tell?
Yeah.
Yeah, adult type coarctation of aorta is usually present late. Presentation will be definitely late. The findings could be hypertension.
Yes.
That is the only presentation. Besides that, they can present with the chest pain. Okay. Secondly, on examination, you will find a hypertension due to femoral delay. And an investigation, if you're going to perform, then the chest X-ray, it will chest X-ray will be showing the notching, rib notching, because secondary to the collaterals. one thing I forget to tell you on the auscultation, the ejection systolic murmur will be there, and the radiation will be on the back. And echo is the diagnostic one. And surgery, either you have to put the stent or end-to-end anastomosis, subclavian flap. While the critical, this critical coarctation of aorta, for the presentation in the early neonatal age group, there is femoral pulses will be there is femoral delay. It will present in the shock, and prostaglandins are the treatment of choice. Like prostaglandin, you have to start later on corrective surgery.
Yeah, but I think there is difference in the position of the coarctation.
Yeah, definitely. Like for this critical aortic stenosis, critical coarctation of aorta, why it present after in the neonates at the second day of life? Because there is the tissue, small tissue, is there that of the PDA that it enter into the descending aorta. So once the PDA is contract, it will also causing the contraction of the descending aorta. So this is the first thing. Second possibility, there is no connection at all between the ascending aorta and the descending aorta. No tissue is there. In that case, you will find absent a pulse also, brachial pulse.
Yeah.
The adult one is also called as a juxtaductal.
Yeah, you're right. 1 minute. I want to show some normal ECGs and we will end the session. Just 1 minute. 125. As you were at that point now, I want to just
Dr. Noor,
uh,
I don't know whether can anyone share the heart sound, abnormal heart sound audios in a group?
I don't know if I don't have it. If someone has, can do that, no problem. Or you can listen it in the internet. If you just put any sound, you will get it.
Okay. Oh.
See, for the right ventricular hypertrophy, R for R. So R wave will be tallest in the V1. And usually if generally you can say it will be above 98th centile. Okay, 98th centile for that age and sex. This is the general statement you can give. Like R wave above 98th centile for in V1 for that age and sex. Okay. But here for left ventricle, R wave will be tallest above 98th centile in V6. This is the ulta, you have to say, tall R wave and deep S waves. Okay, some things important we should know is the tall T waves. Tall T waves you see in hyperkalemia and also ventricular hypertrophy. And sometimes in myocard, main remember hyperkalemia and ventricular hypertrophy. For myocardial infarction, we will remember this ST elevation. Okay. So for flat T waves, again, since hyperkalemia tall T waves, flat T waves will be hypokalemia, hypocalcemia. Most of the things hypo here, hypokalemia, hypocalcemia, hypothyroidism. And also you can get it in myocarditis. Rest all is not important. We'll go for this. Okay, Dr. Sana, this is what you were telling. If you see here in V1, we don't see any R wave here. Most of it is S wave. So if there is right ventricular hypertrophy, we see R wave with upright T wave. This is what you are telling. You were telling me at the time.
No, I was telling you that in the right ventricular hypertrophy, you will find the R wave in the V1. You can see now only the S waves are there.
That is what I'm
In the
telling.
right,
This is normal ECG. So in
yes,
normal ECG, I'm seeing S waves here. But if it
yes,
was a right ventricular hypertrophy, this is the P wave. Okay, I would have seen here the tall R wave and also the upright T wave.
yes, yes.
Yeah, usually in the V1, there will be like this inverted T waves, right? Usually.
Yes.
Okay. And for that, even you can remember R waves, there is centiles and also there is calculation. Not for every child it is the same. So more than 98 centile for their age and sex. So here he is showing, you see, the RVH in ECG of a child, 2 years. Make it little bigger. Here we are seeing the upright R and also T waves.
Any ECG of the normal newborns?
I think there is one. Because in the newborn, the upright T wave in V1 is normal.
Yes. I just want to see the location of the R. Yes. See, here you can see this V1 is up because in the normal unit, there is generally right ventricular hypertrophy.
Yeah, right ventricular predominance, we can say.
Predominance and it is actually hypertrophy because of the increased pulmonary pressures.
Okay, so here we are seeing upright R wave, not like normal.
But it is normal for the neonates.
For the normal, for the neonates, yeah, neonatal ECG in neonates, yeah. I got your point now, yeah. Yeah, see superior axis deviation, just observe the AVF. You'll observe the lead AVF, okay? And observe in a normal child, then observe in the abnormal child. This is the not normal. We'll go for the normal ECG. See the AVF here is upright, right? And one more normal ECG. AVF here is upright, right? So in superior axis, what is happening here? See the AVF here. Most of it is down. Okay. This is W syndrome with a delta wave. Okay, actually, I can't continue anymore. Thank you all. I hope the session was beneficial for all of you. Okay, I will end the meeting.